Hello ladies, welcome to our evening with Dr. Figy. My name is Lori Buckley and I'm going to be your host tonight for the Straight Talk series. And on behalf of Project Pink, our goal is to bring you knowledge and tools to help strengthen and renew your mind, body, and spirit from the moment of diagnosis to the end of life. And we are going to do that tonight, talking about my favorite subject, lymphedema. And we're here with Dr. Sean Figy, and he's just a real treat. You're going to enjoy getting to speak with him. So he's giggling. He's not sure he's a treat. He is a treat. So Project Pink is pleased to present Dr. Figy. He is an assistant professor of plastic and reconstructive surgery at the University of Nebraska Medical Center. Dr. Figy is a plastic and reconstructive surgeon who specializes in reconstructive surgery and microsurgeries with an extra specialty in lymphatic surgeries. So I will hand it over to Dr. Figy and let him speak a little bit about himself and get our night rolling. And ladies, we're just going to do this in a casual conversation, and you're welcome to start texting in your questions that you want anytime, and we're just going to go back and forth with Q&A throughout the whole night. So welcome, Dr. Figy. Thanks for being here.
Yeah, no, thanks, Lori. As Lori said, my name is Sean Figy. I'm a reconstructive microsurgeon at Nebraska Medicine. I did my residency at the University of Massachusetts. I am indeed from the East Coast. Don't hold it against me. And then I did my fellowship in reconstructive microsurgery and complex reconstruction at The Ohio State University, where I learned a whole lot about lymphatic surgery, which is actually not microsurgery, it's supermicrosurgery. It is supermicrosurgery. So it's very, very small vessels, very, very complex reconstructions, but it's something that I've really learned to enjoy, and working with lymphedema patients has been a real treat for me. I want to talk a little bit about what lymphedema is, because I think it's unfortunately something that we historically as physicians have not talked about. And I don't think it's because we were being neglectful. I think it's because we actually didn't know a lot about it. And it's something that when you don't know a lot about, or you don't know how to fix something, we tend to avoid it. Yeah. So I like to think of lymphedema as fluid traffic. So if we think about our arteries and veins as interstates, we can think about our lymphatic system as state routes. So they oftentimes are a little bit kind of curvier, there's more of them, but they have, they're smaller, they don't have as high of flow as the arteries and veins do, but they're really, really important to the function of the fluid in our extremity. So when we have surgery to take out lymph nodes, if that lymph node, which we can kind of think of as a stoplight or an intersection in those state routes, is the only stoplight or intersection in that extremity for those state routes, you get traffic buildup because there's nowhere for that fluid to go. Now, in most people that have their lymph nodes removed, they have enough state routes where they can find some other pathway around, and the fluid can find somewhere else to go to get back to the veins back up in the neck where they eventually converge. But in some people, they don't have enough back roads, they don't have enough connections, and they get that fluid traffic. Now, as that fluid traffic builds back into the extremity, there's only so much room in the roads for the cars to be, so the cars start to fill out into the cellular area. So you get this fluid back up into what we call the interstitial space, which is the space between the cells outside of the lymphatic vessels and outside of the veins and arteries. And that fluid is very inflammatory. So a lot of this comes back down to inflammation at the end of the day. That protein-rich fluid that's now built up into the cells then causes inflammation in the tissue. That tissue inflammation causes scarring. That scarring then causes those lymphatic channels to get smaller, which then allows them to carry less fluid, so there becomes more traffic, which makes more inflammation, which causes more scarring, which causes more traffic. So it's this cycle of chronic and progressive inflammation that happens because of this protein-rich fluid that can't transmit from the arm or the leg, depending on where your lymph nodes were taken from. It can't transport from the extremity back into the chest where it dumps back into the venous system. So that's kind of how it happens, and that's why lymphedema is a chronic and progressive disease, because it continues to make itself worse. It's a cycle. So that's what I think of as lymphedema, and that's how I like to describe it. I think it's, easy to recognize. We've all been on Dodge when there's construction by UNO, and it's not a pleasant experience. So you can understand when you have construction in your roadways, it can cause some traffic and build up. You get that swelling.
It's really cool that Nebraska Med actually sought Dr. Figy out and brought him here just because he is so knowledgeable and his specialization in the lymphatic system. It's pretty unique that Nebraska has. Are you the only one in the area?
I'm the only one in the area, yeah.
He's the only one, ladies. He's the one. He's the one.
That can be a good or a bad thing, depending on how you look at it.
And so that's really, speaks volumes for his skills and talent. So what a blessing to have you here. So tell us a little bit about what the surgeries are, like the basic surgeries that you're doing. Can you enlighten us a little bit on that?
So when I think about surgery for lymphedema, I like to break it into two major categories. So we have a physiologic procedure, which takes care of the fluid component, and then there is an excisional procedure, which as the swelling and inflammation go on, unfortunately, it turns the tissue into a fibrofatty change. So you get this fibrofatty conversion. And it's not normal fat, it's abnormal fat. So you get this swelling that then turns to solid stuff, which is why you get the swelling that never goes down. So if we talk about excisional stuff, excisional surgeries are like liposuction and Charles procedures, which a Charles procedure, please don't Google it because it's not the most pleasant image you'll ever see. But liposuction is a debulking procedure. That does good work for fat and fibrous tissue. It also requires you to have reasonable skin if you go for liposuction. So taking care of your skin is really, really important. The Supermicro surgery that I do falls into the category of a physiologic procedure. So it works on fluid dynamics. So there's two major categories of physiologic procedure. One of them is called a lymphovenous bypass, and the other one is a vascularized lymph node transplant. Lots of words. Lots of words. A lymphovenous bypass, if we break down the word, it's lymphatics, veins, and it's a bypass. So we're connecting a lymphatic vessel to a small vein that's close to it to bypass the obstruction. So we do it downstream from where the obstruction is, downstream from where the blockage is, and we take that lymphatic and then we connect it into the venous system. So we no longer have to go through that construction site. We no longer have to go through that intersection that's been broken. So we bypass that and we allow the lymphatic fluid to be dumped into the venous system in the extremity. That requires lymphatic channels that are still there. So that's for a person that still has enough lymphatic channels that have not been taken over by the inflammation that we can still find them. If you don't have any lymphatic channels, or you don't have enough lymphatic channels for me to work with, then we have to do something different, and then we have to bring in lymph nodes from another part of the body. And the thought process with that is within lymph nodes that have their own blood supply, as the lymph nodes absorb fluid, a portion of that lymphatic fluid actually goes into the venous system right at the lymph nodes. So we can take some of that fluid and it sort of acts like a sponge and it takes the fluid from the surrounding area and then brings it back into the venous system there. So the Supermicro surgery is the lymphovenous bypass and microsurgery is a vascularized lymph node transplant.
So tell them how big is a lymphatic vessel? How big is a lymph node? So they understand what a super surgery it really is.
So we call it Supermicro surgery because these blood vessels are less than 1 millimeter in diameter. So typically the lymphatic vessels that I'm operating on are between 0.3 and 0.8 millimeters in diameter. So if you look at a ruler and you see the centimeter side, you see the little hash marks, distance between the smallest hash marks is actually bigger than the lymphatics that I'm working on.
That's crazy. That's absolutely crazy.
So the entire surgery is done under a microscope. And I've been very lucky because Nebraska Medicine committed a lot of money to this type of surgery because it's a very expensive surgery to start because it requires a very specialized camera and it requires a specialized microscope too. Mm-hmm. So they had to get all those upgrades for me to do this. So I actually have a specific set of microscope and a specific set of instruments that are used just for me, because the instruments that I'm using, the tips of them are actually 0.05 millimeters in diameter. So they're incredibly small and incredibly precise. So they're very, very small for the lymphovenous bypass. Now, when we talk about a vascularized lymph node transplant, then we're talking about connecting arteries and veins to each other. So arteries to arteries, veins to veins, so that we can take tissue from one part of the body that has lymphatic tissue and then bring it to another part of the body and restore the blood supply so it stays alive and can work in that new location.
So when you do the lymph node transplant,
Yeah.
how big of an area are you taking from the transplant area,
Yeah.
the donor site?
The donor site. So there's so many different donor sites, and if you talk to any number of my colleagues, we'll all talk to you about how we have all different donor sites, but we all have kind of preferred ones. So donor sites can come from the neck, they can come from the armpit, they can come from the groin, they can also come from inside your belly. And my preferred donor site, and this is partly because of where I trained and who I trained with, my preferred donor site, if it's safe, is to take them from inside the belly. And that's because every time you take lymph nodes from another part of the body, you're actually putting that part of the body at risk for lymphedema, because you're taking lymph nodes from that part of the body and you're, stealing from Peter to pay Paul.
Right.
And there's ways to reduce risk so that you reduce the amount of risk of lymphedema, so you're only taking specific lymph nodes and not other lymph nodes that will cause lymphedema. But and there's lots of different surgeons around the country that are working on different areas that you can get for lymph nodes. But my personal preference is to go from the belly. Now, the lymph node packet that we're taking is usually about the size of a silver dollar.
Oh, that's not very big.
It's not very big. The blood vessels for that are typically 2 to 3 millimeters in diameter, so much larger in the grand scheme of things, but still quite small, still requiring a microscope to put them together. So the reason I like the belly for these lymph nodes is because there's minimal risk of donor site lymphedema. So we don't have to worry as much about causing lymphedema in the bowel, because we're taking them from either the omentum or from the mesentery.
So because the donor site is so small, then what is the healing time for that donor site?
Yeah.
Compared to just doing the lymphovenous transplant?
So the reason why I like to do lymphovenous bypass first is because even though it's a much more difficult surgery for me, it's a much easier surgery for the patient to get through.
Yeah.
So lymphovenous bypass is day surgery. You come in, we do our surgery, you go home unless you're from very far away, and then I keep you overnight so that you don't have to drive in the middle of the night. So it's typically a day surgery that we do. It's a small incision in the skin, 2 to 3 centimeters in length. We do multiple of them in each surgery. So typically a lymphovenous bypass surgery, we will do anywhere between 2 and 7.
Okay.
To do as many as we can to reduce the amount of fluid in the extremity and put the fluid back into the venous system. Each bypass takes between 30 minutes and an hour and a half, depending on how fidgety they are. They can be quite difficult to work with sometimes, as you can imagine. So that's a much easier surgery to recover from. In terms of pain, it's typically Tylenol and Motrin, and you're golden. It's kind of like if you were to have a small biopsy. It's a very small incision in the skin, so not a lot of pain. In terms of the lymph node transplant, and the reason why I do the lymphovenous bypass first as opposed to the lymph node transplant first, is because the lymph node transplant is a much bigger surgery. In the sense that the donor site, we go into the belly, so there's the donor site recovery, which is 6 weeks of no lifting, and there is a small risk of hernia associated with that. I work with a general surgeon who I work with to get into the belly and out of the belly, so that we have 2 teams working at the same time to make sure that we're 1, efficient, and 2, we're doing a safe abdominal entry and closure. In terms of when you're in the hospital, depending on if it's an arm or a leg, because I also treat non-breast cancer related lymphedema, and so there's other cancers that cause lymphedema from lymph nodes, and also primary lymphedema, which is a whole nother discussion. And for upper extremities, the flap goes into the arm. The flap is the packet of lymph nodes that we take. So if you hear me refer to flap, that is the packet of lymph nodes that I have taken from the belly and I'm now transplanting into the arm. We use a curved incision over the forearm. We go down to the radial artery and we remove a portion of the radial artery and replace it with the blood vessels that we've taken from the belly. So you still have blood flow to the hand, it goes through. The lymph nodes then live in the arm. We take out a small bit of fat so it hides in there nicely. But you have to be in the hospital for typically about 5 days after surgery for that. For a lower extremity, it's more like a week and a half.
So when you do the lymph node transplant and you take that from the belly, do they have to wear a compression garment, a girdle?
They wear
of some
a binder.
Kind? A binder?
They do wear a binder.
Okay.
So that can be a little uncomfortable, can be a little irritating. So we oftentimes will tell people to wear a clean cotton t-shirt underneath it so they don't have the binder touching their skin, just because they can have reactions to it.
How long do they wear the binder?
6 weeks.
Okay.
So it's 6 weeks with that. For all of these surgeries, they don't allow aggressive compression like they would normally have for 4 weeks after surgery.
Okay. So for the first 4 weeks, no compression of any kind, and then after that,
Then we kind of go back through and we do some massage and some kind of the reductive phase of CDT again, the complex decongestant therapy. We go back through some of that reductive phase. We've had pretty good results here so far with fluid resolution. So far we've had a lot of really good fluid resolution. Doesn't mean we can't get better. It doesn't mean I'm not always trying to be better. I think that if you rest on your laurels, that's when you start to do damage. So I am very aggressive about continuing to monitor my outcomes, continuing to try to find better ways to do things, because that's what's right and what we should do. But we are, at 4 weeks, we're allowing them to go back into massage and compression garments to see how much reduction we can get.
So I would imagine the goal is to reduce the amount of compression they had to use before.
Yes.
So what, in general, can you share with the ladies what the goal is for each of your surgeries?
Yeah. So in terms of outcomes, we have to talk about what our goals are. So I will never lie to you and tell you that this is a cure. Unfortunately, we still have not developed a cure for lymphedema. The best cure is to prevent lymphedema. And we're working on ways to do that by, either limiting nodes that we take out, or doing targeted node dissections, or doing immediate lymphatic reconstruction, where after a complete lymph node dissection, we can actually take the lymphatics that have been cut and do an immediate lymphovenous bypass in the axilla to immediately reconstruct those lymphatics. So these are all things that are being worked on around the country to try to figure out how we can reduce the incidence of lymphedema. But in terms of once you have lymphedema, unfortunately, we haven't really been able to develop a full cure. In terms of outcomes for the surgeries, they're pretty similar within a few percentage points. And we talk about two different types of outcomes. We talk about subjective outcomes and objective outcomes. So subjective outcomes are what you're telling me. And the objective outcomes are what I can see. So what can we measure versus what can you tell me? Measuring and feeling. In successful lymphovenous bypass and lymph node transplants, we're having between 86 to 90% subjective improvement. So vast majority of patients are saying they feel better. So we're seeing less pain, less stretch, less discomfort, more use of their extremities so they can feel like they're, human again. I get a lot of people coming in and telling me that they feel like their arm's not theirs. I've had people ask me to cut it off, and I refuse to do that. That will not happen until we try a lot of other things first. 86 to 90% of people are saying they feel better, which is awesome, because we can help people get back to their life, which is great.
It is exciting.
And then between 66 and 70% of patients will say, we can actually measure a difference. Now, the caveat to that is we have to talk about the stage of the lymphedema and the location. So this is stage 1 and 2 lymphedema in the upper extremity is where that data is. When we get to stage 3 and 4, and stage 1, 2, 3, and 4, I'll go into in a second, we have less good outcomes. And that is because when we talk about staging is indicative of disease progression and fluid versus fat. So when we have stage 1 and 2, and lymphedema never follows anyone's timeline but its own. So some people will have had lymphedema for 10 years and still only have stage 1 or stage 2 lymphedema, whereas some people will have had lymphedema for 3 months and it's stage 4. It's all variable based on, the person and how much your lymphedema wants to make you sad. So what we talk about for stage 1 and stage 2 is very good. For stage 3 and stage 4, it's less good, but that's because there's less fluid. It's more fat at that point. So it's going to end up being a combination of things where we have to do a combination of physiologic and excisional, or just excisional if the fluid component is no longer there.
So I will share with you that Dr. Figy did a lymphovenous bypass on one of my patients who was more advanced in her lymphedema, the stage 3, 4. She'd had lymphedema for lots of years. And the one thing that people don't understand about lymphedema is that it's not just about the fluid. That lymphatic fluid is very protein rich. So when he talks about the fat, that lymphatic fluid is like a magnet to fat cells and it just wants to come. So that's part of the reason why you get the 2 arms at such a different size. So my lady had had lymphedema for quite a long time, and she had other medical conditions going on, but hers was incredibly painful, and it was very heavy for her. So like instantly after the surgery, she lost that heavy, achy, like the weight of the world pulling on her shoulder joints, that all of that left her. Now, because she had had it for such a long time, the arm was still bigger than the other one, because of all those fat cells, but to her mentally the arms were the same size because it felt normal. It wasn't heavy and achy. So she didn't even really care that that size hadn't gone down. She was just ecstatic because the discomfort and the pain and the weight of pulling on her shoulder was gone. And even though she was still wearing compression garments, she didn't have to do as much stuff before. She was having to wrap night and day and heavy garments and all that, and she was able to tone all that down. So to her, she was ecstatic and thought it was a huge success, even though the girth hadn't changed. But for the ladies whose girth doesn't change, like afterwards, if that bothers them, can you go in then and do liposuction and get rid of that, because it's no different than the person who goes in and gets their belly?
Yep. So absolutely. And that's kind of been my protocol that I do. So I work on the fluid component first because the fluid is what's causing the problem. So I can either reverse some of the changes or halt the progression of the disease. And if we can sort the fluid out, then our major issue afterward is the fat. So then we can sort the fat out after that. So we can go ahead and do liposuction after that. The hard part about this is insurance coverage for the liposuction is pretty finicky. The insurance coverage for a lot of the lymphovenous bypass surgery is pretty finicky, but I was pretty aggressive before I started. So I signed my contract a while back during my fellowship, and I actually made some trips out here to meet with insurance companies beforehand.
Good for you.
To talk to them about what I do and why I do it and what are some of the outcomes.
Awesome.
So we've actually had pretty good luck so far, knock on wood.
Wow.
In terms of getting things covered through insurance, because I think this
Huge.
is a result of cancer. It's a reconstructive surgery. The argument against it is it's still a newish field. It's not really that new. The first papers in this were described in the 70s.
Yeah. It's newer to the United States, but it's been around for a long time.
It's been around for a while. So it's
the cost of the equipment.
The
is
equipment
huge.
is hugely expensive.
So that's one reason why it hasn't become super popular.
Yeah,
so
again, why I'm super grateful.
good for you guys, yeah.
Yeah, I actually negotiated that as part of I was like, I would like to do this, thank you.
Yeah.
And they were like, okay.
Good for you.
So,
how about Medicare? Does that cover? Is it just private insurances that you're getting covered, or are you getting Medicare?
Makes me nervous.
Okay.
And I haven't had many yet right now with Medicare. But my concern with Medicare is there's no prior authorization. Now, you'll never hear a physician in America tell you that they like prior authorization. We all hate it. But, and prior authorization does not mean that they will pay for something afterwards. Right. So you still might end up getting stuck with a bill, which is awful, and I dislike that strongly. But in terms of Medicare doesn't prior authorize. And if Medicare chooses not to pay for it, then they don't pay for it. So that's what makes me a little nervous about it. I think that I have enough argument that I'm able to argue it majority of the time, but it's one of those things that does make me nervous, and it's something that I'm still learning to navigate. It's when you're a resident and fellow, we operate a lot with our attendings. We work with them in the clinics. We learn all the things that they teach us. And as a fellow, I did a huge number of these cases. But when you become the attending surgeon, it's a whole nother concept of how you practice medicine that becomes, the new challenge. So it's something that we're all kind of navigating together.
It's part of Dr. Figy's big heart. He was here beforehand working with insurance companies, and he, is doing the surgeries. He's going to have to do lots of extra paperwork to try to get your insurances to pay for that.
Yeah.
And it just shows how much he really cares. He's like taking the whole picture into consideration. So
I had very good mentorship. So
I'm going to go off subject here because we got some questions I want to get to. So does lymphedema happen right away, or can it happen a lot later? I don't experience it in my arms near my surgery site at all, but I do have swelling in my legs, and it's quite painful all the time. I realize that's somewhat different, but I'm curious if this is something I have to worry about. My surgery and my lymph nodes were taken out in 2013.
Okay, so long answer, short answer is yes to both. So typically, lymphedema will start within 3 years of the surgery itself. And it's typically isolated to the extremity that's affected. So if you have lymph nodes taken out of your left arm, that will not cause lymphedema in your right leg or your left leg. There is some thought of mirror components, where if you have lymphedema in your left arm, your right arm will swell a little bit, but that's really not hashed out in anything. So when we think about lymphedema, it's typically in the extremity that is affected. Now, 70% of patients will develop it within a year, and 90% will develop it within 3 years. So it's typically within that first 3 years of your surgery, your lymph node surgery, that you will develop lymphedema. We are really terrible at predicting who will have lymphedema.
Yeah, there's a lot to it.
There's a lot. There's so many confounding factors. There's so many different risk factors, whether you're going to get radiation or chemotherapy, how many lymph nodes were taken out. Obesity is a big thing as well. And that sort of makes sense too, because if you have a lot of tissue that needs to be drained of fluid, and then you take out those pathways, there's a lot more cars coming through the state routes. So we have to think that if there's more fluid and you're taking out those roads, there's going to be a higher risk of having that traffic. So obesity is related to it, number of lymph nodes, chemotherapy, radiation.
And I think a lot of that is still in the oncology world. Those physicians are brilliant in the oncology world, and they're working on saving your life. And they don't really think about the lymphatic system a whole lot. They don't have a lot of...
They're getting better.
They're getting better with it.
We're not back in the Hallstedian days of the radical mastectomy, where they take out the entire pectoralis major muscle and everything from the axilla.
So much better than that.
So much better than that.
Better. But it has more to do than just the number of lymph nodes, because it's your whole lymphatic system. Like, what are your lymphatic organs working like? That area in your stomach has over 200 lymph nodes in it. Your lymphatic organs. If you have trouble with a lot of those things anyway, that adds to it too. So there's a lot to it. It's not just the number of nodes that you get taken out.
What we do think about, so what we've identified as risk factors are lymph nodes greater than 10, radiation, chemotherapy, and obesity. That's what we know for sure.
Those are the big ones.
Those are the big ones.
So I was
But unfortunately, I don't necessarily think your lower legs are probably related too much to the axillary procedure that you had. There's a lot of things that can cause swollen limbs. And I see this a lot in my practice too, because a swollen limb is something that confuses a lot of doctors as well as patients. So I see a lot of swollen limbs. As it goes, as you increase the number of swollen limbs you have, it decreases the likelihood that the cause is lymphedema. So the likelihood, if you have all 4 of your limbs are swollen, the likelihood that is lymphedema is pretty low.
If you're taking very many medications, maybe you could have your doctor or your pharmacist look at that, because sometimes your medications, a side effect from that can be swelling in the extremities. So that would be the first place I would look for you.
Absolutely. Talk to your primary care physician. If you have swelling, they can look at your legs. One of the big causes of swelling in your legs is venous disease. And that also is something that afflicts a lot of women too, is venous disease that can cause that swelling if your veins don't push the blood up, and they kind of have what we call incompetent valves that can cause the blood to pool in your legs and cause that swelling and that red kind of ruddy look to your legs that can happen.
Yep, great
but
suggestion.
Things that, for other types of swelling can be heart and liver are all things, and kidneys and protein. So there's so many different things that can cause swelling.
Yeah.
It's not just lymphedema.
Yeah. I was diagnosed 11 years ago and now only visit my oncologist once a year. To my knowledge, I haven't had any issues with lymphedema. Am I still at risk? I had a double mastectomy and 9 nodes removed.
Unfortunately, you probably still are at risk, but that risk decreases every year.
Yeah.
It'll never be 0. But if you've made it this far out, which is awesome, the risk becomes lower and lower each year. But I would say don't worry about it, but know about it. So strength and knowledge.
Yep.
Know your stuff. If you start to see something, you let us know, and then we can address it earlier rather than later.
And your first signs would be just that heavy, achy feeling, just really just in that area. Even necessarily before you have the swelling, it can just be heavy, achy, and tight feeling, and then you can just have somebody check it out.
And that's what we call clinical stage 0 disease. Yep. So clinical stage 0 lymphedema is no noticeable swelling, but you have symptoms. So when we have clinical stage 0, we don't have that swollen limb. When we have clinical stage 1, your limb swells, but it goes back down to normal with elevation or compression. When we go clinical stage 2, it swells, it never goes back down to normal, but it fluctuates in size pretty readily, and you still have what's called pitting edema. So pitting edema is a sign of fluid more than fat. So if you push into the extremity, in your arm usually, for a minute with gentle sustained pressure for a minute, you can see that divoting, and that's what we call pitting. If you have pitting edema, you still have fluid. If you no longer have pitting, it means it's converted more towards the fibrofatty dominant. And that's when we get to stage 3. So stage 3 is a fibrofatty dominant disease, still probably some fluid, but the fat is now overloading the fluid, but you still have good skin quality. And then when we get to stage 4, that's when we get to have the skin that's affected. So lymphedema, because of the inflammatory process, can change the quality of your skin. We get little, what we call papillomatosis, where you can get these little nodules.
So another question, I have a hard raised area above my surgery site. It seems to be growing. Now it's several inches long and several inches high. My surgeon hasn't been concerned, but my oncologist is. I have a breast MRI last month. I had a breast MRI last month and it was all fine. I use a lymphedema machine at night and wear a compression cami, and she sees someone for massage. Do you have any thoughts? How concerned should I be?
Well, I think that if your physicians are doing, it sounds like they're doing their due diligence. They've done imaging. If there's something there, maybe a biopsy. But I leave that to them. The cancer surgeons are excellent at what they do. The cancer surgeons and cancer doctors are both leaps and bounds ahead of me in terms of diagnosis and management of cancer. I, as the reconstructive surgeon, my job is to be part of that team and to help out where necessary. Sometimes, as a reconstructive surgeon, I can help the cancer surgeons by allowing them to do bigger surgeries, and then I can put things back together with different reconstructive techniques. But in terms of the diagnostics, it's not typically where I excel. That being said, if you're concerned about something, it's really, really important that you talk to your cancer doctor to make sure that they are working it up and making sure that they're looking at it. If there is that swelling, it could be scar tissue, it could be something, it could be nothing. But it's important to have that thing looked at. Imaging, it sounds like you already had that, and if there's some concern for some sort of growth, maybe some sort of biopsy.
Yeah, because the MRI was fine last month.
Yeah.
Yeah, so
So there's
the
lots of things that it
oncologist
could be.
hopefully can just keep watching that for you.
Now, if you start to have aggressive swelling of the arm or you have a lot of pain, that becomes a different story. That's something that if you start to see, if you are many, many years out and then you have painful, aggressive lymphedema, that's something that you should get checked out right away.
This one you've partly have answered already. Does the radiation increase my chance of lymphedema? Does cording play a role in that, the axillary cording syndrome?
So it does increase your risk. And that's because radiation is also one of those things that destroys the state routes. So radiation causes radiation fibrosis. It causes the blood vessels and small vessels to scar down. So it causes a lot of scarring. So then you're adding another barrier for the fluid to get through. So radiation does increase your risk.
Do you feel that axillary cording plays a role in that?
I don't know. If I don't know something, I'll tell you I don't know. So I'm not. My ego is not so big that I can't say that.
Yeah. All right. Does stage 4 present an issue for coverage?
Stage 4 does not present an issue for coverage for certain things, but it does change what you're a candidate for. So it changes what you're a candidate for in terms of what surgery you would benefit from. If we have really rough skin quality, it becomes an issue for what can you heal. So if I do a lymphovenous bypass, will you be able to heal the surgical incision that I do? Because I don't want to cause such a problem that you can't heal it and then you end up having a wound where you did not.
And the rest of that question was, does that play a bigger role if it's a Medicare patient? And kind of answered that before, that Medicare is an unknown at this point.
It's kind of an unknown for me, and it might. It's definitely less of an unknown for probably my faculty that I trained with, and I'm on the phone with them a lot about these kinds of things because I know the surgeries and I know the diagnostics, but when it comes to navigating the insurance world, they've been doing it for longer than I have, so I'm on the phone with them a lot. I owe Roman Skoracki a lot of presents at Christmas time. Because I'm on the phone with him far more than I think I probably should be. He's also the nicest man in the world. So.
Aww. How does chemotherapy impact my risk for lymphedema?
So chemotherapy does also impact because chemotherapy is inherently scarring as well. So when it comes down to it, we have to think about what causes scarring and what causes fibrosis. So when we have the scarring and the fibrosis, you can have impacted flow through the lymphatics. So. And it's not necessarily all chemotherapies, but some of them. But it's just one of the things we look at as what are the risk factors for it. Again, it doesn't guarantee you lymphedema or guarantee that you won't have lymphedema. Again, we're not very good at figuring out who will and who will not develop lymphedema. Part of that's going to be better recognition of symptoms and better recognition of signs so that we can better monitor that later, and also it's going to be better data collection for who develops and who doesn't.
I had 3 nodes removed, which they say is low risk for me. It is. My question is, should I still avoid using that arm for blood pressure?
That has been largely debunked.
Has it?
That has been largely debunked, which is great. I mean, so if they do end up using that extremity, it's not the end of the world. I'd say, use the other one preferentially, but if you need to use that one, you don't have to worry too much about it. So we've loosened a lot of the restrictions on that, and we work with the surgical oncologists and the breast surgeons, and I'm super lucky to work with the breast surgeons that I do at Nebraska Medicine. So we have 3 excellent breast surgeons that just do breast surgery, and they are fantastic to work with, and we work with them pretty extensively on this as well.
I fell in December of 2019 and landed on my right elbow. My breast cancer and lymph nodes were removed on the right side. The pain went away after the fall, but it has returned. It hurts when I put my arm rest, when I put my arm on an armrest. My surgery was 3 years ago. Any thoughts on this? Is it lymphedema or something else?
Can I take a look? I just like to read sometimes. So it's right-sided elbow. It could be. So sometimes we do pretty well with do pretty well after surgery, but it takes away some of your reserve. So injury, like falling on your elbow, can cause inflammation. It can cause an upheaval in the amount of fluid that your arm has to transport. And that can be just enough to tip it over the edge and cause that. So it could be like a clinical stage 0. It could be something else as well. So as long as they've done some x-rays and they've, looked into make sure of that, I think common things being common, it's probably orthopedic, but it's not unreasonable to think that it could be lymphatic if the orthopedic issues have been sorted.
Yeah, I would check with an orthopedic person, If you pinpoint it, is the pain really just right here in this one spot, then I would probably go to the orthopedic person first.
Yeah. So common things being common, it's if you fell and you had a trauma, the orthopedic thing is probably the more common thing, but it's not unheard of to have an inciting agent like that cause the start of lymphedema, especially in our primary lymphedema patients. Usually what happens for our primary lymphedema patients which is a lymphedema that's caused by it's not caused by having your lymph nodes removed, it's more of a genetic issue. They'll be fine, and there's something innocuous, like I rolled my ankle and then my leg swelled up. And that's typically the story that we get. And sometimes they don't even recognize that they've done anything because it's such a small injury.
I get this question a lot. Does my port increase my risk of getting lymphedema?
I don't think so.
Yeah, I don't think so either.
They're different parts of the body.
Yeah.
Your port gives you good access for chemo. Let's go for it.
Yeah.
So.
And they're not really messing with any of the lymph nodes
No, they're not.
or vascular system to do that.
So the port usually
really
goes
light.
into your subclavian vein, which is underneath your collarbone. So your lymph nodes are farther away from that. So it usually doesn't affect that too much.
Yeah. I was given 30% chance of getting lymphedema. I had 8 rounds of chemo, 37 rounds of radiation, 15 nodes removed. My surgery was in 2019. Would you say my percentage of getting lymphedema is higher than 30%?
So actually that's kind of where we say it, like 30 to 40 is kind of, if you have all of those things, 30% is not an unreasonable risk percentage. So I'd say that's probably a reasonable risk. You are what we consider high risk, and I'm sorry about that. But it is something that if things do happen, we can work with. Yeah.
But it doesn't necessarily mean that you'll get it either.
Exactly.
So
that means you
don't bring it on by worrying about it.
The bright side of it is if you have a 30% risk of getting it, you've got a 70% risk of not getting it.
Yes, amen.
Right?
Yeah.
Virtual physical distancing high five. We are physically distanced as per CDC and Nebraska Medicine guidelines.
So
we've also used alcohol prep a lot and washed our hands a lot. And none of us have actually shaken anyone's hands. No, there's been no hugs today.
No. So the signs you would look for again is just the heavy achy feeling in your arm first, unless you saw some, and then swelling would be one of the next things. Your jewelry getting tighter, or the sleeve of your shirt getting tighter. Those would be things that you would look for, or they would be your first things. We don't want you looking for them,
especially
but they would
in
be
the
first
dependent portions of the extremity.
Yeah,
so along the ulnar border or behind the arm here, that typically is where I have a lot of people coming in with symptoms.
So let's see. So it is, do want you to realize that it isn't a cure, but it's really great. The surgeries are really great for those of you who are having discomfort and pain and that sort of thing.
So I think it's really important to focus on the fact that this is not a replacement for therapy. It's not a replacement for the garments and the durable medical equipment that you need. It is an adjunct. So it's really important. I work very, very closely with our lymphedema therapists in the Omaha area and even beyond, because Nebraska is gigantic comparatively to where I'm from. So we work hand in hand with our lymphedema therapists so that we can make sure that we're giving excellent conservative measures in addition to excellent surgical measures.
So even though it doesn't cure it, lymphedema itself is progressive. So having your surgeries, would that really slow down the progression of that?
So that's the thought.
A great deal? I mean,
yeah, so that's the thought.
That's a huge goal for those of you, especially people getting it young,
Yeah.
you know?
So that's a huge hope for us. And we think that we're doing that pretty well. So there's actually been evidence. So they've done lymphovenous bypasses on patients, and they've taken biopsies of their skin at the time of lymphovenous biopsy or lymphovenous bypass, and then afterwards. And they've actually seen a reversal, not a resolution, but a reversal of the inflammatory changes in the skin. So we do have clinical evidence, pathologic evidence, looking under a microscope of resolution of some of those inflammatory components that we see with lymphedema, which is really, really exciting.
So here's another really good question. It leads me to a couple of questions. One, sometimes you don't have the lymphedema in the arm. Mm-hmm. They can have it just in the breast or in the trunk. Can you do surgery for the lymphedema that's in the trunk?
That presents a bigger issue, because what we don't want to do is we don't want to create a pathway for cancer cells, should they come back, God forbid. We don't want to create a pathway for those cancer cells to go from the lymphatics into the bloodstream faster. So typically when we have lymphedema of the breast or the torso, that's going to be something that we do differently, because that's an area where, especially the breast, if there's lymphedema of the breast, that's a very, very difficult problem to treat, because there's concerns about cancer management.
So at this point, the arm is really what you're looking for.
At this point, we're really just focusing on the arm. There's some other things that sometimes it's not so much a lymphedema of the breast, it's a radiation fibrosis or a fibrosis that's caused by scarring. And there's some other things that we can consider doing for that to help reduce some of that kind of woodiness that you get with radiation. So we've been working with some fat grafting as a way to do that. And fat grafting has been excellent in terms of reconditioning radiation fibrosis. We've seen some really excellent results with that, but it doesn't necessarily affect the fluid component of it. That would be lymphedema.
So that's one of the questions we have here. Someone who is thin and has a lot of radiation scarring or fibrosis, and that's what's created her lymphedema because of that. That's when you would use the fat transplant for that?
So we can do fat grafting for that if there's a lot of radiation fibrosis and a lot of scarring. What I like to do is if I have a person that has a lot of scarring that's causing a contracture, that's a really great opportunity to do a vascularized lymph node transplant. Because vascularized lymph node transplant brings in lymphatics, but it also brings in a lot of soft tissue. So if you have a contracture of your axilla, so you can't raise your arm, you've got this cording that's going, you can release that. But if you release that without putting something in it to prevent it from recurring, it can actually be worse. So that's a really great time to use like an omentum, which has a lot of tissue and a lot of lymphatic tissue, to open up that contracture and then put that free flap in there with that lymph node, with all those lymph nodes to help release the contracture and also bring in some lymphatic tissue.
Oh, super cool.
Yeah, pretty nifty stuff. I'm a huge nerd.
That is cool.
Huge nerd. And that's okay. That's a compliment in my family. Being a nerd is like the nicest thing you can say to someone.
I had one axillary node removed, no chemo, no radiation. Got lymphedema real quick. This lady uses a pump and she has it under control. She had the deep surgery, flap surgery, and imagine that's what caused her lymphedema in her abdominal area. Is there any help for that?
So the lymphedema is in the abdominal area, or is it in the arm? Because there's some concept that doing free tissue transfer actually is a little protective for lymphedema.
It said it affected the lymphatic system in her abdominal area. That's what the question says.
So that is not something I've seen a lot of. Some of the hard part about DIEP flap is you get numbness along the incision, especially below the belly button, and that numbness can actually feel like swelling. So I haven't seen a lot with that. It's not completely unheard of at all. There's a lot of lymphatic tissue. My worry would be more for lymphedema of the lower extremities with a DIEP flap as opposed to of the abdomen itself. So that could be some numbness that you have feeling with that, which is still an abnormal feeling, and I can understand how that'd be not comfortable. But I haven't seen much with the DIEP flap causing abdominal donor site lymphedema.
All right. I had 18 nodes removed. My arm is often uncomfortable, sometimes more than others. I have always contributed that to the lymphedema, even though I feel my lymphedema is always present, but does not seem But you don't really see much of it. Is there anything I can do for that?
Well, symptoms being symptoms, that's clinical stage 0 if you don't have swelling. If you don't have swelling, you have lymphedema. That's clinical stage 0. It sounds like pretty classic symptoms in terms of the lymphedema itself. If you have swelling but you don't think it's that bad, we have to talk about what quality of life is. And it would be something that I would have you come into my clinic. I would see you, kind of evaluate it for myself, and then part of the diagnostic process is after I've seen a patient and figured out whether there's fluid or fat or if it's lymphedema, we have to do what's called an indocyanine and green lymphangiogram. And that's something I do in my clinic, and that's one of the things that
Say that again real slow so everybody gets it.
Indocyanine and green lymphangogram, right?
You could almost make that a chant.
You could. You could. I'm not interesting to do that, but you could, 100%. So an indocyanine and green lymphangiogram uses a dye called indocyanine and green, which is a dye that when it binds with protein and flows through the lymphatics, and we can actually use it to map the lymphatics. So when we use a special camera that uses a near-infrared camera, it uses a near-infrared photon, it excites this compound, and then picks it up as we read it, we can actually see the lymphatics flowing through the extremity. So we have them come in, we do injections in the web spaces of the hand and on the wrists, and we can actually see the lymphatics flowing through the extremity. And I can see whether they're functioning, I can see where there's areas of disease, I can see, where are you going to be a candidate for certain processes and certain procedures. So I do that, and that allows me to see kind of what you're a good candidate for.
And you would do that for pretty much everybody before you do a surgery on them,
Before
correct?
I do any surgery, that is a prerequisite for having the surgery, because that tells me what surgery you're a candidate for.
Very good.
So that's part of pretty much all of my workups. Other diagnostic testings that I will oftentimes use are magnetic resonance lymphangiography, which is a new program that we're building at Nebraska Medicine that uses MRIs and dye injected into the skin, so we can actually look at the flow of lymphatics through that. That is a longer test. It's a study that's done by the radiologists, so we're working on that as well, but that can kind of tell us deeper structures, whereas an ICG lymphangiogram, the indocyanine and green lymphangiogram that I do, really only looks at lymphatics that are within 1.5 centimeters of the skin surface, which is why it's really important that you go to your lymphedema therapist and have really good compression and get as much fluid out as possible, because it allows me to see a lot more lymphatics that way. The other things, lymphoscintigraphy is something that we will sometimes use. And then you'll see me running around clinic with my tape measure, and I do lots and lots and lots and lots and lots of measurements. So for diagnostics, we do a lot of those things.
Very good. I had 22 nodes removed during my surgery 6 years ago. My right arm is larger than it was prior to surgery. On a day-to-day basis, I don't have huge issues. My lymphedema usually only bothers me when I'm walking with my arm dangling at my side. If I walk with my hand at my wrist, my arm doesn't hurt as much. Is this common?
Yeah, it is.
Yeah, it is.
And everyone experiences lymphedema differently too. So you give me 100 women with lymphedema, and I'll give you 100 distinct sets of experiences and symptoms. So everyone experiences it differently. So is it common? Yes and no, because everyone has a different experience, but I would say that's a very easily attributable complaint for lymphedema. You had a lot of lymph nodes taken out, my dear.
Yeah, that's a lot.
That is. But yeah, that would be something that if it bothers you, that'd be something that we would take a look at, and that's why that's when we're talking about symptomatic management, those are the types of symptoms that we can help.
And if you're someone who doesn't wear a compression garment, if you knew that you were going to go on a long walk, maybe if you just wore it during that time, that sometimes helps with the achiness, just something you could do until you got to see Dr. Figy and had surgery. I think you answered this question, what makes someone a candidate for the surgery, and what would disqualify you?
Disqualifications, active infection.
Definitely.
Active infection, which unfortunately lymphedema is associated with increased rates of cellulitis. You'll also hear us use the term DLA, which is dermatolymphangioadenitis. It's a mouthful. So DLA. They're interchangeable. So for cellulitis and DLA. But if you have an active infection going on, we are not going to operate on that. We'll wait till that infection clears. If people have a lot of infection, it actually makes you more of a candidate for the surgery because we want to try to, decrease the rate of that. What qualifies you as a patient is if you have a fluid-dominant lymphedema and you are good about going to your therapy, because we need to make sure that you can take care of everything that after we do it. Again, therapy and surgery go hand in hand, so we have to make sure that we're doing everything right and making sure that we're giving ourselves optimal environments for healing. So if you're not able to participate in therapy, that becomes an issue. But those are some of the major disqualifications.
Mm-hmm. And I would think, sum up that a little bit, if you've had lymphedema symptoms, whether it's the pain or even the swelling for more than 5 or 6 months and you've tried conservative treatment, then I think that it's appropriate to go seek out Dr. Figy, and he could possibly help you with that. So on the flip side of that, the lady who's had lymphedema for years and years and years and has one arm a lot bigger than the other, they could still be a candidate for you. They're just not necessarily going to see a great reduction in the size, but the symptoms would be a lot different. So really, it doesn't matter how long they've had that, they would be somebody that you could look at.
Yeah, absolutely. And I think we have to be very clear about what our goals for surgery are. Because if I do a surgery on you and I tell you that I can cure your lymphedema and then I don't, you're going to be very angry with me, which is reasonable. I'd be upset with myself. But we have to look about what our goals are and what are realistic expectations. So if a person's had lymphedema for a long time and they have a huge fat component as opposed to a fluid component, I can take care of some of the fluid, which will help with that stretch sensation. And sensation-wise, they'll do better. But if you were looking to have your arm smaller, you're not going to be happy afterwards, and you'll feel like we didn't do a good job. So I try to be very clear about, and if any of you have seen me in clinic, you'll know I'm pretty honest about what I think we can actually do. I try not to pull any punches with that, because if I sell you this like mystical surgery that's going to cure everything and then I don't do it, you're going to be very angry, and that's reasonable. So I try to be very honest with what realistic expectations are going to be. And as long as we're on the same page with that, that would be something. Back to an earlier question, what would disqualify you is if you have unrealistic expectations for what the surgery can do. If you think that I'm going to be able to cure your lymphedema and you're never going to have to wear compression therapy and you're never going to have any problems ever again, then I can't meet those expectations. And I know that. So rather than put you through a surgery that's going to make you miserable, that would disqualify you from surgery. So our goals have to match reality.
But on the flip side of that, the one thing that lots of people might not realize about the lymphatic system is it's really what I always say, like the garbage dumping truck of your body. It's getting rid of your toxins. So if you don't take care of your lymphatic system and it just gets worse and worse and worse, that increases your chance of getting infections. So if you're the person who's ignored, lots of times women early on will ignore it because they think wearing the compression is too much. And so then their arm grows and then they decide, okay, now I need to do something because it's different. You could still benefit from those surgeries with Dr. Figy and, get rid of that achiness and then do some debulking and get rid of that girth, but you'd have to be compliant then afterwards in wearing the sleeve.
Absolutely.
So you still would really benefit from his surgery. You just have to be compliant afterwards. And
it becomes a process too.
It's a process.
So it's not, I'm not the type of doctor that you get to see once and then never see again. So that's either a good thing or a bad thing, depending on what you think of me. But I'm the type of doctor that you'll get to see for a long time.
we're almost done, so a couple quick questions. I was told I was one of the rare cases where compression made my lymphedema worse. Is surgery my only option?
I've actually never heard of that.
I would say the only reason lymphedema, compression might have made your lymphedema worse is if it
didn't
was
include
way
the
too
hand.
small, or you were fitted wrong,
And
or
it
something
didn't
like
include
that.
a gauntlet glove, and it made the
Yeah.
swelling distal to it.
So to me, it would be if you were put in the wrong thing, maybe.
Yeah, because that's
So
confusing.
hopefully, if you saw somebody else and you did treatment, that would still help you and get
Yeah.
your lymphedema back
And
under control.
It's important when you go to a lymphedema therapist. Not all therapists are lymphedema therapists. So occupational therapy and physical therapy are both different types of therapists that see lymphedema patients, and they both do an excellent job. But lymphedema therapists are people that have gone to specialized training in lymphedema. So you have to make sure that you're looking for people that have experienced lymphedema and work with lymphedema patients and have had that additional training in lymphedema. Which, Lori, you are one of them.
I'm one of those.
She is one of those.
The last question. I have active lymphedema in my arm, but it's not as bad as it has been. I can take it, but it's the burning and tightness in my armpit that gives me the most discomfort.
Yeah, so that, is all symptoms of lymphedema. If we can work on some of the fluid, we might be able to benefit some of that. What we found is that if we put lymph nodes distal, or if we do distal bypasses, we have better resolution of the fluid from the entire arm. And that sort of makes sense because fluid is lazy. Fluid is that teenager that doesn't want to do anything. They don't want to mash potatoes or take out the trash. It's just going to kind of drop down.
And if you're just wearing a sleeve, or you're just doing this kind of motion to try to empty that out,
It's
you
gonna
might
end
be
up here.
pulling it here. So you got to make sure you're taking it all the way down and out of that whole entire area.
Yeah.
So we're almost out of our time. Do you got any last closing thing, thing you want to share or highlight you think we should have hit?
I think we hit a lot of great things. Lymphedema is a really interesting topic to me. In the medical profession, we don't understand everything about it, and that can be frustrating for a lot of people. I'm super lucky that I get to work here and that I found a place that will support, the practice of lymphedema surgery and supermicro surgery, so that I can, do this kind of work, which I've really found to be gratifying and enjoyable. So bear with us. We're working on it as a specialty.
We're trying.
We're getting better,
Yes.
but we're not there 100% yet. So a lot of what we're doing is evolving and changing, and how we do things. And do we do lymphovenous bypasses only, or do we do vascularized lymph node transplants only, or do we do them in concert with one another? It's all in flux, and we're all trying to figure out the best way to take care of people and the best lymph node donors to use and the best techniques to use. So we're not there yet where we can say this is the best way to do it, but we're all trying. So bear with us.
Thank you very much, Dr. Figy, for joining us and giving us your time tonight. It's always a treat to get to visit with you. I could talk to him forever, as you know, because I'm going over my time, so I'm sorry, ladies, but thank you for that. If you have any questions about lymphedema or any questions that you wanted Dr. Figy to answer, you're welcome to email those to me. You can just do the Project Pink email, or you can do lbuckley@projectpink.org. And I'll be happy to answer those. And if I can't answer them, then I will get Dr. Figy to help us out with that. So, survivors, thank you very much for joining us. Please share your thoughts on the topics for tonight. Stay tuned for Project Pink on our social medias for any updates for things that we have going on. We're going to try to do a little bit more live webcast things for you, so we can still be following our mission and strengthening and renewing your mind, body, and spirit, and keeping you going, because we're here to help you into that thrivership. So thank you so much. We appreciate your time. Love you all. Good night.
Stay safe and wash your hands.